Hi, Claire. Sorry.
Hi,
How's it going?
I'm good. How are you guys? It's good to see
Good.
you.
Good. Yeah. Good to see you too. Okay, well, we're kind of talking today, Claire. Well, why don't you introduce yourself first? We obviously know you and you're in our office, but do you want to just like introduce yourself and tell us like kind of what you do and what your business is?
Sure. So my name's Claire Walsh. I'm a registered dietitian, and I own a private practice called Clarified Nutrition, um, which was the most exciting naming experience of my life. And I have two children, so you know, I was really pumped when I came up with that one.
That is a really good one.
Thank you very much. So I use an intuitive eating and functional medicine approach to help women get past their hormonal and GI symptoms without feeling restricted and obsessive about food.
Love it. Cool. Okay, how did you get into dietetics and your kind of like specialty with hormones and stuff?
Sure. Well, I never wanted to do anything medical. And then in high school, they told me I would maybe have a better chance of getting a scholarship if I took 4 years of the science credit. And my friends were in anatomy. So I took anatomy and my world totally changed. And I was like, this is amazing. I love this so much. Purely because my friends were in that, like, never would have ended up there otherwise.
Yay.
Yeah, it was really coincidental. And I explored a bunch of different options, and I've always been kind of interested in food and cooking. And dietetics seemed like a really good fit. So that's how I ended up studying nutrition. And I've done a lot of different jobs in dietetics. Never wanted to be a business owner.
Same.
Uh, yeah, right. It sounded terrible. Like you have
Yeah.
to do accounting and you have to know about like clinical stuff. No, thank you.
No.
Why would I want to do that if someone else could do that for me?
Right.
Um, but I tried it all, man. I worked inpatient, I worked outpatient. I was a professor for a couple of years. I did a community group education. And as it turns out, I really like making my own rules. Um, and there's I've always had a big interest in like, functional nutrition and integrative medicine and how we can use nutrients to like help the body work better, and finding a way to practice that way in someone else's clinic was really hard. um so I ended up where I am, kind of as a last resort in some ways, because I really didn't like working for other people. Makes me sound like I don't play well with others. I do.
You do. Yeah.
Thank you. Yes, you
We work
work
together a
well
lot.
together.
Yeah.
Uh, but yes, like with hormone stuff, I started learning a little more about the female hormone cycle, like menstrual cycle and ovulation, when I started, in my anatomy and physiology class in college. I learned that birth control has an impact on your ability to build to your peak bone mass, which was brand new information to me.
I don't
I've
think
been
I
a
learned that in anatomy, so that's really cool that they went over that.
My anatomy teacher was really fantastic.
Yeah.
She was great. So, and I'd been on birth control for a number of years because I had had really awful cramps in high school. And I was like, wait, I'm sorry, I may not be able to build enough, like my peak. I might have higher risk of osteoporosis because of this medication I've been on for 6 years. And like, no one told me that. What the hell?
Yeah.
Um, so I started to get more interested in the hormone cycle and what all that impacts, and read Tony Weschler's book, I read the part that was relevant to me. That book is huge. uh Tony Weschler's book about taking charge of your fertility, and like learned about the cycles. And when I you know got a big girl job, it was like, you know what, if I get pregnant now, that would be a bummer. That would not be like my ideal schedule, but it would be fine. So I came off birth control and I managed some of that stuff and continued to see that come up every once in a while in my practice, like in my jobs. Um, I would notice women having like odd hormonal things and think like, gosh, that's just that can't be right. That's not what this, but no one had any real answers for it. And I, in my through my own journey that way, I got more and more interested and more people asked questions. And I just sort of dove into it because I found it fascinating. And I had a patient actually in my, I don't know, second or third year as a dietitian. I had a patient with PCOS.
Mhm.
She was really struggling with fatigue and stress resilience. So she would get overwhelmed pretty easily. And she was gaining weight, but her exercise and her food intake was the same. And the doctors really didn't have a good answer for her. And so we were chatting and like, energy balance looked appropriate. And I didn't really have a good answer for her either. And I could kind of see, I know that there's something wrong, and I feel like nutrition is a part of this, but I'm really not sure. I really don't know what the answer is, and I just kept thinking about her, and so um, the more research I did after I had moved on from that job, it was like this is something that's interesting and important to me because I really saw how it impacted her life and um, really wanted to be able to do better the next time someone with PCOS came along.
Love
Is
it.
a really good answer.
No, I love that. That's great. So kind of that kind of leads us into that like that patient. I feel like that's so cool. I was just thinking that those like patients that kind of like change the course of your
Mhm.
career a little bit are just like
Mhm.
so like just kind of cool to think about. So, um, but I guess to kind of back up, tell us kind of in general like what because you like to work with people with PCOS and like that kind of stuff, right? So tell us kind of because I feel like I see it and then I have people who get diagnosed or they don't get diagnosed. To me right now, it kind of seems like it can be like a little bit of a catch-all, but then there are some people like some OBs like won't diagnose it unless they have like a certain number of cysts. But then other people will be like, well, you have cysts, but you don't have these symptoms. Can you just kind of like tell us a little bit more about like maybe what that is or like if you know about like what the requirements are to get diagnosed or if it even matters. Sometimes it's like, does it matter?
Doesn't matter is a really good and interesting question. And I feel like from my perspective, from a treatment standpoint, not really.
That's how
Um,
we kind of feel in PT. I'm like, I don't know if I necessarily care sometimes if you have a diagnosis because I'm treating your symptoms, right? So,
yes.
yeah.
Yes. Like I can see with my lab work that I do with my clients, like you have insulin resistance and inflammatory issues and like a real need to focus on improving mineral status. And that's what we're going to do, whether they give you a diagnosis of PCOS or, who I don't care what they say. But I know that from a patient standpoint, having a label for a struggle that you've had for a long time is really that can be really affirming. It's like
Yeah.
this is just in your head. So doesn't matter, like not necessarily for what we would do together, but I know that that can be really clarifying for someone.
Hmm.
So it stands for polycystic ovary syndrome. PCOS does, and it's a complex metabolic disorder that impacts how our body uses energy and how it produces sex hormones. And there's a lot of kind of underlying drivers that can lead to some of the symptoms that we see. In order to get a PCOS diagnosis, there's three criteria. You have to meet two of the three criteria, and you have to have other causes of those potential criteria ruled out, which
Gotcha.
I think sometimes is the thing that makes this a little bit confusing. Not everyone is doing the rule out process.
Gotcha. Okay.
So the Rotterdam criteria is what's consistently used. It's you have to have anovulatory cycles, which most people are not tracking whether they're ovulating. So that just for most women looks like missed periods. Like maybe you'll go like a couple months without getting a period. Um, Clinical signs or biochemical signs of hyperandrogenism, which mean hyperandrogenism would mean like higher levels of male typical sex hormones like testosterone and DHEAS. So sometimes that presents with acne, hair growth around the face, the chest, the nipples, the stomach. Sometimes we'll see some hair loss, like male pattern type baldness. We can see some like abdominal weight gain is another potential sign there. So you can either observe those signs just as a symptom, or you can get lab work that says, yes, your testosterone and or your DHEAS level is high. Either one would count as a positive in the Rotterdam criteria for PCOS diagnosis. And then the third criteria is observing lots of cysts on an ultrasound, which are technically not cysts. They're immature egg follicles.
Okay. Makes sense.
Yeah. And that just means it's because those show up because we don't have, in the typical hormonal cycle, we should see FSH rise towards the beginning. Like when you're having your period, FSH is follicle stimulating hormone. That's your brain telling your ovaries, like, get one of those eggs ready. We're gonna send the signal and tell it to get released to potentially create a baby. And then we see estrogen rise, and then we see LH rise, and that triggers ovulation, the release of an egg. With PCOS, LH is often a little bit elevated all the time, which impacts the ability of FSH to be effective at stimulating follicle growth. And so you get a lot of really immature looking eggs showing up in an ovary and they're not being released.
Awesome. I mean, not awesome, but that like makes a lot of sense. I don't think I knew all of those pieces. That's
Yeah. Well, I mean, the name is kind of confusing
yeah,
because,
right. Yeah.
I mean, they sort of look like cysts on an ultrasound, I guess. I, from what I can, from what I read and hear, I'm not like an expert at reading ultrasounds by any stretch of the
Sure.
imagination,
Yeah.
but they're not the same as a cyst. Like those cysts that you hear people burst and it hurts a lot.
Yeah. Okay,
Right.
that makes a lot of sense because I feel like I have people who have PCOS, but then are like never, I mean, you hear when people say that they have a cyst burst, it's like very painful. So you
Yeah.
would think that would happen more if you had PCOS because you would have more cysts, but they're not technically cysts.
No, no, they're
That makes
technically
sense.
immature eggs.
Okay.
You can have like those ovarian cysts can coexist with PCOS or they can exist without PCOS. They're totally different things.
Gotcha. Okay.
So it
Interesting.
should be like poly immature egg syndrome.
Yeah, there are some interesting discussions happening in the like medical community about renaming PCOS.
Yeah.
Mm,
It is a little bit of a misnomer
Right.
and um reconsidering what the criteria are because with like you can have anovulatory cycles or missed periods and you can have lots of little immature eggs on an ultrasound for all sorts of different reasons.
sure. Yeah.
That's where that exclusionary criteria really comes into play. It is really important. Like I have a client right now who had a PCOS diagnosis and wasn't responding to the more typical hormonal therapy that they would have expected from someone with PCOS. So they finally send her to an endocrinologist, and the endocrinologist is like, "Yeah, I don't think you have PCOS. Hypothalamic dysfunction. I think
Um,
that's why this isn't going the way that we would expect it to."
So that's where
Uh,
we're getting like that, like kind of broader, like people are getting diagnosed with PCOS because they're not ruling out like other things that could be causing.
yeah, well, and
Okay.
to be fair to whomever diagnosed her with PCOS, hypothalamic dysfunction is pretty rare.
Okay.
So
Yeah. So that makes sense.
it would not be hard to see, like if it looks like a duck and it quacks like a duck, you're gonna
Sure.
find a duck, even
Yeah.
though like geese are similar.
Yeah.
I don't know,
Okay.
the forest part there. Um, but yes, that it is confusing. And I can't remember what some of the names were, but really it's the hyperandrogenism piece
Mm.
that is kind of the hallmark of more the more classical presentation. And it's important to rule out things like hypothalamic amenorrhea and thyroid disorders. Those cause the same issues with period frequency, and immature follicle growth too.
Hmm.
Looking at those hyperandrogenous hormones, is that just like on your general CBC or is it a specialized lab work?
It's specialized lab work.
Okay.
Yeah. And so you would, remember with PCOS, it's kind of useful, interesting to see what the actual data says, but you don't actually need to get a blood draw, a hormone draw, in order to get a PCOS diagnosis. If you have acne and facial hair growth or like nipple,
Okay.
chest, stomach, like if you have hair growth where it typically would not belong on a woman, that's enough to show. And
Okay.
even it's not all that common for someone's testosterone to be like maybe in the upper third of that reference range, but not technically over, and still have hyperandrogenism symptoms, because we
Mhm.
can also look at things like low sex hormone binding globulin, or sex hormone binding globulin sort of like binds to testosterone, and so that there's not as much free testosterone. Um, so we can still see issues there. And then I don't this is a little less common, but there are some of my clients who don't have high testosterone. They have high DHEAS,
Right.
which is another androgenic hormone, but it's produced more by the adrenal glands. And so the presentation is different. And I've noticed when clients will bring me their hormone panels from their doctors, that one doesn't always get measured.
Mm.
Yeah, there's a really wide variety of.
Interesting. Yeah.
I would love to like someone make some rules about how we do hormone panels. That would be great.
Yes. I mean, I think
They're
that's why people have a hard time getting them, because it's like you,
mm,
I mean,
Like, would you have to specifically order each one of them kind of a thing?
um y- yes, I think you do have to order each individual hormone. And then the other thing that's kind of tricky about hormone panels is that hormones are supposed to change throughout the month.
Right.
So the reference range really varies depending on
Yeah.
where you are in
yeah.
the cycle. Like if you're someone who doesn't have any concept of where you are in your menstrual cycle, then certainly testing testosterone and DHEA, those don't shift and change. But like testing FSH and LH, not that useful
Yeah.
unless you know where you are. Testing progesterone, not useful unless you know where you are. Um, and it like to get useful data from hormone blood draws, you have to test FSH and LH, like around day 3 is ideal for FSH. And then you can use urine strips for LH once you get closer to that mid-cycle potential ovulatory period. Progesterone ideally is about a week after ovulation. Like it's kind of tricky to time
Yeah.
that correctly.
I mean, it makes sense though. Yeah, that you would want all of that information. So I guess like if you're someone that's like going in asking for like you feel like your hormones are off or maybe you have PCOS, is there like do you tell people like this is how I would ask for like a, or is it just kind of depend on the person? It's
Usually I I'm not gonna start with blood labs for hormones
okay,
because
gotcha.
ordering it is complicated. I'm gonna start with let's talk about what is happening throughout your cycle and see if we can't track signs and symptoms of ovulation and measure the amount of days between your periods. Because if you
Okay.
are having a period every 26 to 32 days and you have two signs or symptoms verified with ovulation, and you're not having significant period symptoms, then you're fine.
Okay,
We don't
gotcha.
we don't need blood lab confirmation of that. We can look for other things that are a little less invasive, like cervical mucus. That's something that's relatively easy to monitor. Um, Basal body temperature is annoying to monitor, but super helpful from a like, did you ovulate? And from a metabolic standpoint, you know,
Okay.
metabolism is heat creation. So that's another kind of interesting thing we can monitor to see if we're sometimes I do that with my thyroid clients
Okay.
just as a monitoring mechanism.
That's so
I
interesting.
would start there. I would start with
Okay.
cycle tracking. And if we're seeing some weird stuff that's hard to interpret, then I would go and figure out blood labs. And I do send people back to their doctors, and I always want to communicate with the OB or the primary, whoever is managing obstetric care.
Yeah.
But you can also see a lot from it's called a Dutch test, dried
Mm-hmm.
urine test for comprehensive hormones. That gives us more insight into not only the levels of some of those sex hormones, but also the metabolites, which is a useful way to see, all right, you're producing a ton of cortisol and your body is converting that into cortisone. Like that tells us a little bit about our stress response. So when if I'm gonna order blood or hormone labs for somebody, I'm gonna probably do a Dutch test instead
Okay.
of blood.
Gotcha. Does that, because I feel like there's mixed, this is probably, I don't know, we don't need to get like too much into that, but is there a reason why some, like I feel like OBs don't typically order, or primaries don't typically order a Dutch test? Is there like, is it just kind of like one of those things that like they just don't know how to read it and that's why they don't do it? Or do you know?
A lot of work to learn how to read it. If you
Okay.
ever read a Dutch test report, they are
Confusing. Okay.
and confused. Once you know what the graphs mean, then it's like, oh, this is actually way better. Why don't all labs report like this? But you pull it up and it's this kind of complicated web of these little circles. I remember the first time I looked at one, I was like, oh my God, what have I done?
What have I done?
How am I gonna make any sense of this?
Yeah.
So there's definitely a learning curve to being able to use them, and they're not covered by insurance.
Okay.
So that's another piece of the puzzle.
Okay. Yeah. Those are pretty much the main reasons. Okay, cool. So that kind of tells you more about hormone stuff. So Dutch testing, and then sorry, we're looking at the next question and then I got distracted. But that was leading me into, I guess, like, is there a certain like demographic, or is there someone that you're looking at that's like, okay, I'm probably like I'm gonna keep my eye out for PCOS? Like, does birth control, like being on birth control a long time affect that? Or is it like, yeah,
That's a good
hereditary?
question.
Yeah, hereditary.
There are some hereditary trends. Like we do see the PCOS more common along and hyperandrogenism in general along familial lines.
Hmm.
It's not quite as specific as something like cystic fibrosis or
Okay,
sickle cell anemia, where it's like there's one specific gene
sure.
that has been, there's a specific SNP. We don't know that, but we do see some familial trends. And it's like globally, it's up to 15% of reproductive age women. And it's mostly reproductive age women who get diagnosed with PCOS
Okay.
because most of the symptoms have to do with your menstrual cycle.
Okay.
But because PCOS is a metabolic disorder,
Yeah.
it doesn't like go away.
Right. Yeah, that's interesting.
People who have PCOS long term are much higher risk for things like type 2 diabetes, cardiovascular disease, mood disorders. Like that's why this really matters.
Mm-hmm.
Certainly
Right.
impacts our ability to get pregnant, but long-term health outcomes, morbidity and mortality over the lifespan, it really has a big impact there. Um, it's about 10% of the women of reproductive age in the US. In the Middle Eastern, North African population, it's like closer to 20 or
Oh
35,
my
depending on the
gosh.
numbers. So like if you're from the North African Middle Eastern region, like your risk, I guess, is much higher.
Interesting.
Family history. And then I think about, people who are not cycling regularly or
Right.
have prolonged acne. Um, there's a lot of overlap with, and anyone who has PCOS and Googles what to do about is gonna get some super helpful advice. Uh, super helpful advice. So we do see, because of some of the hormonal changes that happen, and insulin resistance is a big hallmark
Yeah.
of the condition. We also see leptin resistance, which is a hormone that is created in the GI tract, and it tells the brain you're full.
Mm,
Higher levels of insulin, we have higher levels of leptin, and that we start kind of getting that signal. So it is common for people in larger bodies to have, or for women in larger bodies, um, well, common for women with PCOS to have a larger body. It's not exclusive by any
sure.
stretch of the imagination, but it is a little bit more common, which is why most of the time you'll see, if you Google, it'll be like, oh, just lose some weight. And fairy will sprinkle fairy dust over this and you'll lose weight and everything will be fine, which is not true.
I hate that advice.
That's lazy medicine.
Yeah, lazy medicine
Also,
is definitely.
physiologically, if you have insulin resistance and leptin resistance, weight loss is going to be really challenging. Like
Yeah.
it's not probably going to work, which is what usually happens when people come to me, as they say, like, I got this diagnosis and my doctor told me to lose weight and I tried and nothing happened. And then I tried some more and nothing happened. And then they were like, you're not trying enough. Like, and now I don't know what to do because I'm really trying so hard. And
That's so sad.
it is sad. Yeah, it's really frustrating. Really wish people would stop saying that.
Yeah. It's like shocking to me what I hear people say, like even about just like pelvic floor symptoms, like doctors will tell them that they have incontinence because they've gained weight. And I'm like, I don't know that that is like
For sure. Yeah.
at
Yeah.
all, they're like, my doctor told me like I should just lose weight for my back pain or like I'm like, well, you probably gained weight because you can't exercise because you have back pain. So
Right.
like those are maybe related, but it's not
No, we can't say that weight gain is the cause of everything.
right.
That's not how statistics works.
So
It's very, very different. And, like the other thing that really annoys me about this is I see this a lot with arthritis. Patients will come to me and say, like, I want to lose weight so that I can fix my arthritis. I'm like, listen, that's not how that works.
yeah.
Listen.
Skinny people also have arthritis.
Yeah.
This is not exclusively the problem of people with larger bodies.
I don't
Okay.
understand where that came from because I'm pretty sure like the research shows that like arthritis, like it's kind of like the back pain thing where like they're maybe related because like if you have arthritis, it's like harder to move and exercise.
Sure, yeah.
But
And
like again, there's no like correlate or like there's no causation between weight gain and
no,
arthritis, which I'm like,
no,
why? I don't, someone just being like, you should lose weight. Like again, really just
just
bad advice.
we're just really trying to find all the ways to legitimize our weight bias.
Yeah.
Which is like normal neuroscience. The brain really wants to be right. It's very, very good at wanting to be right or trying to find reasons to justify why it's right. But
Yeah.
so you probably notice that if you have PCOS, you Google what to do about it, you'll see recommendations for weight loss. And I would just skip right on past that. Not helpful. Not going to solve your problems.
Yeah. So finding like, I guess then the root cause of like, we've kind of talked about like what those root causes are. Is there, I guess, maybe like two types of questions, or two like into this, but is there a way to like either, like if you don't have PCOS, but you're like wanting to kind of prevent that? I don't know if there's a way to prevent that or if it's just like kind of like, trying to do all the things to kind of keep stress levels low and like generally stay healthy, if that's like kind of the answer there. But so like that, and then also like, is there, it's probably individual, so I don't want to like ask you for too specific of a question, but is there like a general kind of like treatment plan after you like get the hormones, you're like, okay, you have PCOS, and then like, is there kind of like a general like, what does the general treatment plan look like as far as?
Yeah. Well, from my perspective, I do like to kind of dig a little deeper and figure out what are the drivers here. Like, have we made sure that the thyroid is not causing some of these problems? I've seen
Mhm.
that a couple of times, hypothyroidism and
Right.
PCOS diagnoses. There's a lot of overlapping symptoms. Um, so I like to look there, and I want to kind of figure out, all right, where are the holes as far as nutrients
Mm,
in your routines and in your stores. So I like to get some additional lab work, and I like to look at mineral levels and how can we support that? Are we addressing, are you resilient to stress? Most of the time, women with PCOS really struggle with that. So then we can kind of address that from two different angles. How do we decrease our input of stressful things,
mhm.
as much as possible? Increase our, that's like a whole other conversation.
Sure, yeah.
Increase our ability to process that. And then how do we make sure that your body has the resources that it needs to manage that
Right.
stress? That's huge. And that's where a lot of that stress resilience comes from. So I work on, first things usually is making sure someone is eating enough. If you've got hypometabolism, underactive metabolism for whatever reason, then it's going to be really tricky to get your body to do anything calmed down wise if it's getting the sense that there's not enough resources for what it needs to do. So we want to make sure you're eating enough. We want to build meals that are going to promote better blood sugar regulation. So that means including carbohydrate sources along with protein sources. We want to eat regularly throughout the day.
Mhm.
Uh, Intermittent fasting does have some research that shows it's beneficial for like men and postmenopausal women, but specifically with reproductive age women, we see intermittent fasting decreases thyroid hormone output. It decreases metabolism. That's
Mhm.
very likely not your friend.
Yeah.
So we want to get people eating on a regular routine. Doesn't have to be like breakfast is at 8, lunch is at noon, no deviations. But if we can narrow and be more consistent with the windows between meals and snacks, that's helpful. Um, ensure they're getting enough protein, ensure they're getting enough sleep. And then often with PCOS, we spend some time with insulin resistance. And I like to think of this from the standpoint of like, all right, what nutrients, how do we not spike the blood sugar up quite as much? That comes from the meal planning and physical activity work. We can make a
Mhm.
big difference there.
Sure.
What are some of the nutrients that the body requires for metabolizing carbohydrates, and how do we make sure that you have enough of those? So B vitamins, hugely important
Mhm.
for metabolizing carbohydrates into energy. Iodine is important for energy intake. We know potassium and magnesium are a big part of helping cells be more receptive to insulin. Um, so I do some testing with mineral status, and we can get a little more specific into where someone's gaps are, but by looking at some of that testing, um, and we can assess B vitamin status that way, and that's kind of my long-term goal there. I also, a lot of the time with PCOS, there is often kind of an inflammatory component, like IBS and PCOS really do
Mm.
overlap a lot.
Okay. Yeah,
Um,
that makes sense.
yeah, and so and that plays a role in like how we metabolize hormones. The last phase of getting rid of extra estrogen is pooping, so gotta make sure we're doing that.
Yeah.
um
Are
and
is estrogen also elevated in PCOS?
It can be, and we can see, so there's a pathway where testosterone gets aromatized into, like, it gets converted into estrogen. So we can kind of see high testosterone levels lead to higher estrogen levels.
Gotcha.
Some of the symptoms that women with PCOS can have around their cycles overlap with some higher estrogen symptoms, like heavier bleeding, pain, breast tenderness. That's a relatively common sign that we're like dealing with a little extra estrogen. But extra hormone, that can be kind of a tricky thing to assess, because maybe it's not that you really have too much estrogen. Maybe it's that you're just not getting rid of it appropriately.
Right. Right.
Which, fun fact, requires B vitamins. And
So interesting.
Apparently I'm ordering B vitamins.
I know.
and that's one of the things, like, there are very few supplements that I would say consistently for everyone is a good idea. Myo-inositol, for someone with PCOS, that's very likely not going to hurt. There's a lot of good research to show that helps improve ovulation rates. It's helpful for making your cells more receptive to insulin. There's some
Interesting.
evidence that suggests it can bring down DHEA levels, which is really great. So
Yeah.
even if you don't have a suspicion of insulin resistance, it can still be helpful, and it tastes pretty good.
What is it? You said
You
a
said
big
a
word.
really big word.
Myo-inositol.
What is that?
It was classified as a B vitamin originally,
Okay.
but our bodies actually do make it. Women with PCOS have a different ratio of myo to D-chiroinositol. I'm really conscious of my big words now. Uh,
You're just throwing these out like we know what they mean. I'm like,
Like I can't spell that to Google it.
Inositol is INOO.
I'll have you send it to me and we'll put it in the
Yep,
like
that sounds.
description. I don't think anyone's gonna, but I love that. I believe you for
I feel
sure.
smart until I talk to Claire.
I know.
Okay. All right.
I mean, same.
I go
You
read
tell
a
me
book
anything
after
about muscles, and I'm like, oh, okay, fascinating. You said something about fascia the other day, and I was like, what is that?
All right. Fascia is a lot simpler of a word than
That is true.
I can't even repeat what you said if I tried right now.
And inositol.
Inositol.
But I thought it started with an M.
Myo.
Inositol is a form of inositol. MYO-INOSITOL, I think.
Now we're in a spelling bee. Fascia is FASCIA. Did I spell that right?
I think so.
I was like, oh crap. Oh no. Oh jeez. Okay.
Sure, that was right.
I love it. Well, sure. No, that's okay. We'll put it in
the show notes.
yeah.
Yeah.
Show notes. I love
It's a
it.
really harmless one, and the only thing that I've ever seen anyone struggle with from taking it, if you like go a little too hard, a little too fast, sometimes you get kind of gurgly belly and loose stools, but then you stop and it's fine. So
Great.
it was classified as a B vitamin, but it's a part of the complex that like opens the door of the cell to let glucose come in. So with
Gotcha.
insulin resistance, insulin takes glucose out of the bloodstream and holds its hand, walks it over to the cell, and then insulin says, "Hey, cell, open up. I have something for you." And the cell like is not hearing. Whoever is in there supposed to answer the door has headphones on, doorbell's broken, who knows? They're not answering the door. And inositol is a part of that compound that's supposed to come and answer the door. So that can be a helpful thing.
Interesting. That's really cool.
Yeah, it's a nice little visual, thinking about like the thing that gets up off the couch in the cell to let glucose in.
Love it.
Yeah, it was super helpful for me when I like framed it that way.
Yeah, it's great.
And
I love a visual. So
visuals are amazing. And B vitamins are a big part of like turning glucose into ATP. All the first or a cofactor for all of those. Anybody who ever had to take biochem, I'm sure you've blocked that out of your life. Yeah, you
I remember
probably
the ATP cycle, yeah.
cordoned that off your memory and shoved it because it was likely a really confusing experience.
There's lots of words like iositol. So.
Yeah, lots of those words. That is true. Although I don't think that we learned about that in biochem. Anyway, I took like trying to remember when did this start sinking in? My third, probably like the third semester of biochem-esque type classes.
That makes me feel better.
Oh, okay. That's why we're talking about this. I get it now.
I feel like that it's making sense because and maybe you can like help me actually put this into the visual or a visual, but because I just know that exercise helps with insulin resistance because of kind of similar, like it helps with that cycle and like uses
Yeah.
and it
So
just let you take over.
active muscles can pull glucose from the bloodstream without the
Okay.
use of insulin. So even if you have insulin resistance, when you're using your muscles, they can pull glucose and it sort of like bypass. I don't know how they do it,
Sure. No.
but it bypasses that need for insulin. So you don't have to spike insulin levels. And with strength training, that tends to last for like a while.
Yeah. Okay.
So
That's what okay, cool. That's the part that I know.
yeah. Well, that's really important.
Yeah. So kind of connecting, this will be kind of our last, just to kind of summarize, because I don't want to make it like too long, because I know this is kind of like you are doing an excellent job, but it is, I know it's like a lot of information, so I don't want to make it like too long. But so kind of connecting that like pelvic health component with kind of what you do to just like explain that. And I know we've worked together a lot, but because like we're educating people on like strength training, especially when we have like hormonal imbalances. I know it's super important in like menopause also to kind of help with strength. I'm assuming maybe not for the exact same reasons, but just like to help with.
I mean, we see increased muscle loss as we age. So there's that. We want to preserve that muscle mass, but also estrogen and progesterone, the sex hormones that our ovaries largely are creating. With menopause, we're not creating the volume of those hormones any longer, and estrogen and progesterone have some insulin sensitizing impacts. So simply by not creating higher levels of estrogen and progesterone every month after we go through menopause, then our cells are going to be a little bit more insulin resistant. So that is another good plug for building muscle mass and staying active, because those active muscles can kind of help make up for that loss of sensitivity to insulin.
Makes sense. Okay, cool. Yeah. And then is there anything, I guess, else that you commonly see with PCOS? I mean, we have a lot of overlap as far as like pelvic health and PCOS, but is there anything like specific that I guess you see that a lot of times people struggle with? I feel like for us, like we treat like kind of symptoms of periods, and then like a lot of times like if we have hormonal imbalances in like the vulvar area, that can like impact muscle function and things like that, and pain and stuff. But
I
yeah,
do see pain with periods pretty frequently, like really painful cramps, and I know that's something that can be helped with movement and releasing tension in the pelvic floor. And then all of that really impacts our ability to poop.
Yeah. And pooping is important.
Super important. Super important.
And people
So
are always shocked when I tell them it's important, like for hormones, like shocked.
Yeah.
They're like, what?
I know it's such a fun fact that there's a whole, like, if you're interested in a really fascinating rabbit hole, then you can Google
Always am.
estrobolome.
Where?
I know. Should I get a whiteboard and spell it out?
We do have a whiteboard here. Maybe we should
have like vocabulary class with Claire.
See, I have like a tendency to way over answer people's questions. I gotta work on that.
I want to know, like
I
I
love it.
want the word
Yes.
sent to me in a text
Okay.
so that I can Google it. It's just hilarious because you're like, I thought you were gonna say like estrogen and pooping. No, stroll.
You could try that. That would possibly work too. But if you're interested in more of the research stuff, then the estrobolome, it's like estrogen and microbiome together. So there's this whole really fascinating interaction between specific microbes and estrogen metabolism that occurs, especially when we have higher levels of specific enzymes in the colon. I'm trying not to say the words.
We've
shamed her.
No, you're right though. It's we had to do an assignment in grad school where we made some sort of education material, and they were like, it has to be 3rd grade reading level. And I just really sucked at that.
The good news is you're not condescending at all.
No.
That's good.
You know what I mean? I would rather have it be this way and I'll tell you that I'm dumb, and versus like you being like, do you understand?
There's a little bacteria.
Well, and it's not dumb. I mean, I know this word because I've watched a lot of webinars and I think it's
Yeah.
fascinating. I
Yeah.
never would have come across it
Yes.
in normal life. Otherwise, if I didn't find this fascinating.
I love that. Okay, so we're gonna get the B vitamin word, and then the estrobolome, which is estrogen microbiome, and
Yeah.
that kind of
Or
goes.
probably just Google estrogen and microbiome. That would also work.
Yeah, there you go. Well,
And
I'm
I
gonna
bet the estrobolome word will also just like come right
think
up.
that's kind of a fun word.
I
So
kind of like it.
It is a fun word to say.
estrobolome. Yeah, sounds like a cool, like, I don't know.
We should no, never mind.
No, you got it right now.
I get shamed all the time about talking about research.
Well,
And so I almost said we should do like fancy word of the week. And then I was like, nobody cares about that apparently.
Rachel, we were trying to come up with a social media post, and Rachel was like, I know, for the hook, we'll say research. And I was like,
That's
I
not
don't
the
think
hook.
that's not the hook you think it is.
Okay.
yeah, you got to know your audience, I guess, if you want to use that kind of a hook.
So for a lot of us, it might be. I just wasn't sure if it was like a general public hook, you know?
Yeah, it's a little more niche. So to speak.
Yeah.
Yeah, so maybe there's a niche of people who want to hear words like estrobolome and what they mean.
I love it.
There's
Well,
got to be, right? I mean, there's got to be.
I think probably if anyone's watching this far, they definitely are interested.
It is.
So, yeah.
I feel like we could do one of those things where, people will bury, text me this word in terms and agreement, and I'll give you $10 if you've made it this far.
If you,
DMV estrogen.
if you email us the word estrobolome, we'll find a prize for you.
I'll give you a prize.
I will find you a prize.
We're gonna have like 600 people.
That's.
I hope so. I hope that they're all.
I hope so too. I will gladly give 600 people a prize
There
if
you go.
600 people email us. So,
Yeah.
Okay, that's awesome. So,
Thank you.
constipation, pooping, hormone balance, very important. And then also like strength training. And I feel like there was another thing we talked about that were kind of like the overlapping things, but you gave us so much information. B vitamins. Yeah. Anyway, that's like a lot of information too on just like what PCOS is. I learned a ton.
Yeah.
I think I kind of like vaguely and roughly knew what PCOS was, and like, but this is super helpful.
Yeah.
And
So glad.
yeah.
Happy to help.
Yeah, thank you. I'm sure we all learned a lot and some new words. So yay.
Yes, and I learned. Gotta work on the vocab.
No, you should not at all. We loved it. This is perfect.
For the plot.
Yeah.
We love you and we think you're perfect.
And this is how we know like you were a professor, So we'll just start calling you Professor Walsh, and then when you use words like that, we'll just say, okay, Professor Walsh, How's that?
That works for me.
Okay, good. But we appreciate it so much. It was
Yeah.
super informative, really, really helpful. So
That's great.
great job.
All right. See you guys later.
Yeah, see you
Okay.
later. Thank you.
Bye.
You're welcome. Bye-bye.